So I do have the honor of moderating our first session with the woman next to me, one of the very smartest, most dedicated, and passionate people I know, and from whom I have learned so much, and as many of you know, is a Jersey girl. Dr. Reinhard is the Senior Vice President at AARP, where she directs our Public Policy Institute, the focal point for state, federal, and international policy research. Susan oversees PPI's teams, multiple, working on health security, financial security, and family, home, and community issues. And from that vantage point serves as editor-in-chief of Policy Plus Action, the AARP Public Policy Institute newsletter. So if that job isn't enough, she also serves as chief strategist for the Center to Champion Nursing in America. She is a nationally recognized expert in health and long-term care with extensive experience in conducting, directing, and translating research to promote policy change. Her Jersey roots are deep. Previously, she served as co-director of Rutgers Center for State Health Policy, directing national initiatives to help people with disabilities live at home. She served 3 governors of the great state of New Jersey as deputy commissioner of the New Jersey Department of Health and Senior Services. Her research and policy expertise includes healthcare, workforce, caregiving, consumer choice, community care options, and quality. A former faculty member at Rutgers College of Nursing. She is an American Academy of Nursing Fellow. She holds a master's degree from the University of Cincinnati and a PhD from Rutgers University. Susan, we are so happy you made time for us this morning and can't wait to hear your presentation.
Any older, that's going to get longer, huh? It's embarrassing. Thank you. Thank you. Well, first of all, it's so great to be here. It really is, as you've already noted, seeing, I call her Judy, but Commissioner. Thank you. And Dave and Andy and others that are in the audience. But all of you, I don't know everybody in this room. I wish I could get to meet more of you. State Nurses Association, thank you. But hopefully I'll get to meet more of you. I assume some of you are volunteers. Are there volunteers in the room? Can you raise your hands? There we go. Wow. That's great. You know, one thing that is not in that bio that I think is worth mentioning is when I was deputy commissioner, the AARP state office reached out to ask me if I'd be on their executive council. David's on it, right? You're on the executive council now. And I got to meet them. I was like, wow. I mean, it was like a Supreme Court justice. It was the ombudsman. It was like, wow, this is like an amazing group of people. So I've always really obviously liked AARP enough to go work there, right? But it is an organization that really believes in change through volunteers, through its members. So thank you all for the work that you do. So I was asked to kind of provide a conceptual framework is the way they put that. That sounds so academic, I realize. But I want to note that we have 2 people following me, and it's Rebecca Priest, right? And Rebecca can get more into the details of greenhouses and small houses. We were going to have someone who works with her, but she's unfortunately ill. And then Robert Jenkins, who has extensive experience in the financing and the scaling of greenhouses. So I'm trying not to step too much into what they're doing and to warn you that I'm not going to cover all those things because they're coming up next. What I thought I would do, and I checked this out with Ev, because she has to tell me what I should be doing. But to start off with a little level setting of kind of like, I asked the question, how do we get to nursing home institutions in the first place? How do we get there? And I know my friends over there could probably give a whole history lesson and maybe some others. So I'm just going to talk about it briefly, because when I was talking to Ev about it, she said, you know, I didn't realize nursing homes are fairly new. The model we have are fairly new. And I think that helps us think about change. It's not as if it's been around for centuries. It's been less than a century. Very important changes. So just very quickly, initially, well, think about it. People didn't live that long, right? So as time goes on, it's like, wait a minute, you know, where can we get extra care? And initially it was more like mom and pops I hate that term, right? Mom and pops, but that's the term they give, right? And so very kind of informal. And then and a lot of these changes came through policy. So that's another important factor for those who are involved in policy. And around World War II, 1946, Congress passed the Hill-Burton Act. Anyone familiar with the Hill-Burton Act? I'm sure some people over there are, right? That was a big deal. It gave grants for nursing homes to be built in conjunction with hospitals. And it gave, so basically that's how we got the hospital model to begin with, because that's where the money went, to look like hospitals. And it made sense. People need care. So where do people get care? Well, they get care in hospitals, right? So it wasn't a stupid idea. It was a pretty good idea at the time, I think. And then the second part of that was it gave government control over the building and regulating them, which, again, is not a bad idea, right? We should be, but that sort of formed this whole model back to what did hospitals look like in the 1940s? I don't know if any of you know that, but they had wards. They had semi-private rooms. You were lucky to get a semi-private room. Think of the shows you see on TV, the walking around and the soldiers coming back, and they're in these big wards. I worked at the VA in East Orange. That was my first job. Huge ward, huge. They were lucky to be in a 4-bed ward. So that's the model. It's how you evolve, right? Then I would say that, I think it was in the 60s, right? So then you come to the financing part of this. So the 60s brought us Medicare and Medicaid. And so now there's more of a financial stream for this kind of care. In the 70s is when it really took off. So am I saying anything wrong, guys? You're okay with that, right? Checking my facts here. That means you started fueling this model. That's like 50 years. And that's when everyone's like, really? Wow, that's not that long. So together, there's people in this room that might have been alive when this thing sort of started, but definitely most of us here were alive as it started booming. So that's what we have. We have a model that made sense probably when it started, but does it make sense to us now? Is this really the model for our future that we really want now? You even started seeing, like in the late 80s and 90s, assisted living. That was a reaction also. Like, we don't want this institutional type model. Let's make it more home-like. Of course, I was saying that the East Coast made it more like hotels with chandeliers, and the West Coast, it made literally more home-like. So I think people around here, you just said, I've never seen assisted living without chandeliers, right? so that, maybe that model should change. It's like, this is what we do, we create things. So is it possible to change? And I think that's where we have to start. The commissioner said we can change. I'm assuming if you're in this room, you are somewhat interested in change, knowing that there are, Andy and I were talking about this before, knowing that there are obstacles, there are barriers to change, there are details to change, which Robert's going to talk about. Thank you, Robert. I think that'd be great. I'm not talking about those. But can we change? And can we get to a consensus around that? And perhaps the commission is where you're going to get to some agreement that, no, we really do want to change and take on those barriers that are going to happen. And there are things that have been occurring. So there's the pioneer movement. There's the person-centered and resident-centered care movement. There's, I meant assisted living. And then there is this greenhouse or small house model that we're here to talk about more today, which is not brand new. I went to, the first time I went to one was almost 20 years ago. How many years? Yeah. So it's been there. There's evidence around this. I'll talk a little bit about this. This has been pretty well researched. And COVID, we can get into some of that data too. But how do you scale it? When you come up with really great ideas, what makes it move? And what stands in the way of making it move? And I'm not saying there's just one model. But we're going to talk in particular about that because there's some evidence. And I wrote 3 papers about it, right? So that's why you invited me. So I'll talk about that. So there are many forces for change. I would say that people in this room want to see some change, right? What are the forces for some of those change? Well, preferences of consumers. There aren't many consumers that want to live in a 4-bedded ward. Anyone know anyone? Maybe with their sisters and brothers. Maybe if you had a big family. Even then, I don't think so. I'm one of 6 kids. I don't want to be hanging out with them the whole time, right? I still want my own room. So preferences of consumers. New Jersey, as one of the colonial states, an older state, we have a lot of nursing home buildings that really do need changes. They're older, they need replacement, I'll just say, or some kind of remediation. And there's a lot of capital investment that goes into that. So how do we want to spend that money? As long as we're going to be spending it, how do we want to spend it? And then there's the pandemic. There's more factors, but just moving things along. Then there's the pandemic, the costs of COVID. So you just heard the commissioner and you just heard Stephanie talk about the numbers of what was happening. Everyone in this room was appalled. I mean, I don't have to tell you how heartbreaking this was, watching it unfold and feeling so helpless as it was going. And yes, we were taking actions. I know Ev was always screaming for more attention, AARP screaming for more attention, and indeed attention came. But it's been amazing. I started something called the Nursing Home Dashboard on COVID in 2020, thinking we could do it for a couple of months. We're still doing it. Every month we put this out. And we take data from, it's federal data. It's actually data the nursing homes give to CDC and CMS. We just take it and make it a little more simple because there's a lot of data. So we look at, resident cases and deaths, staffing cases and deaths. It used to be PPE, that's not as much of an issue now, staffing, and we look at vaccinations. We're very much looking at up-to-date vaccinations now, which are still really, really difficult. In fact, there's only one nursing home in New Jersey that has a rate of up-to-date vaccinations in the high 90s. The only one, was only one. I won't tell you which one because I don't remember. I'd have to look it up. So we do better. I'm not saying we don't do anything, but we have far to go, and everybody here knows that. What else, though? What about the money? The money that had to be spent, infused in every state across the country. COVID was very, very expensive. There's no doubt about it. And that focus brought attention to small nursing homes. You started seeing in the press before you started seeing even in research, like, wait a minute, what's going on? What could possibly make a difference? And newspapers were talking about it. And why were they doing it? Well, one was infection control. Like, how does that help with infection control? I'll share some of the data, but the single rooms, right? You know this. Single rooms, you're more likely, if you don't have somebody living with you in another room with you, never mind 3 or 4, you're much less likely to catch anything, never mind COVID, from one another. So consistent staff, I want to get more into that. You don't have as many, this model, I'm using the greenhouse model now, the consistent staff means and the universal worker model, which Rebecca will talk more about, means you don't have a lot of people coming in and out. There was a very interesting study that Yale did, and it looked at cell phone data. And you can only do this once. In fact, I don't think it's allowed anymore. But they looked at the numbers of contacts going between nursing homes. They called it shared staffing. And it could be staff, it could be nurses, it could be doctors, it could be CNAs, et cetera. But it could also be the beautician or a physical therapist or what have you. They were just looking at the numbers of people using cell phone tracking data. It was amazing. They have it for every nursing home in the country. But of course, that's a frozen piece of time. It was like the 2020. But it was pretty amazing at how many people go in and out of nursing homes, each time able to bring infection with them. Community spread, as they like to say. Then there's also the easy access to an outdoor space. Because we know you have to get outside, you know you need fresh air, it'd be nice to visit with family, and this model has that easier access. And I'll leave that to Rebecca, you'll talk more about that, right? Okay. Now let me just talk about the studies, a little bit about it. So Dr. Cheryl Zimmerman, University of North Carolina, well-known, in fact, she just got a major award at the Gerontological Society of America, has been studying long-term care in many different ways. We're talking external evaluations, so it's not biased, it's looking at the data, what's going on. And what they find, just incredible evidence. Let me just say, breathtaking evidence as far as I'm concerned, and I look at data a lot. 95% of greenhouse homes reported zero cases during the worst period from February 2020 to May 31st, 2020. Zero. Well, we were like, oh my God, what's going on here, right? Now, there's only 300 something. How many are there, Rebecca? 362 around the country. So these are small, but that's out of looking at all of them. That was looking at 3,200 residents. Pretty compelling. And that's when the newspapers were picking it up. The press was like, wait a minute, why don't they have any cases going on? If you have no cases, you have no deaths either, right? So that was pretty impressive. In terms of cases now, I'll just say, so the deaths in going through the whole year, it's about 3 times as many if you are not a greenhouse. I'll put it that. So you're right, Rebecca? Yep. So, people did eventually, because of community spread. It's not like nothing ever happened, but much, much less. And in 2021, it's hanging in there. So it's a proven model in terms of cases and deaths. So what is it that we need to change when you talk about small homes? We like to talk about size. That's why we call them small homes, right? So they're small. And there's the physical architecture, the 10 to 12 people. Does anyone have 14? At one time I heard 14. Okay. Oh, even 16 now. Okay, so still very small, private rooms. We'll show some pictures in a moment. So there's that. But if I leave one thought with you today, it's about the staffing model. It's both. But you can't you get some effect of private rooms, for heaven's sakes. I don't mean to take that away. But if you're going to get the data that I just shared with you, that effect, you have to affect the staffing model too. Because that's where you get not as many people coming in and out. That's where you get relationships. That's where you get quality of life. So and we'll talk, and definitely Rebecca will get more into that. So let me just show you some, you have the papers. I'm sure you're all going to read them, right? All 3 of them, right? We'll have a little quiz later, but you don't have to. How do I turn? There it is. So this is like the first one I went to visit. They don't all look like that. Rebecca's going to share different models. Is that the one you're in? All right, there's Rebecca's. So it looks like it's in a neighborhood, right? Looks very, very nice to visit. By the way, I remember Bill Thomas saying his measure of quality in a nursing home or quality of life in a nursing home. Remember, he started with Eden Alternative. Remember we did that years ago? The Eden Alternative. And he said the measure is how many cars are in the parking lot. I just really love that. When you're checking out choices, Commissioner, as part of that, I found that fascinating. Like, who's visiting? Do children come and visit, or are they too scared? When you walk in, do you smell popcorn? What do you smell when you come in? But anyway, this looks very inviting. There isn't a big parking lot for one thing. So that's part of what it looks like. Let me just see. I think I can, is it here? Yeah. So size matters. I do want to say that size matters. But look at this. This is what really impressed me the first time I went. The hearth they talk about, right? It sounds kind of silly, right? It sounds like the chandelier effect. Like everybody's got to have a hearth. Everybody has to have this kitchen where you sit around. It just sounds like, oh, come on. Do we really need that? But it does work. It really works because where do people hang out in your house? Right? So that's why it's built on that. It's what do human beings like to do? They like to eat. They like to communicate. Maybe they will help make the meal. That's part of it. Can the Shabazim engage them in making the meal in some way, or at least sitting there and watching it and being part of that feeling? Look at the kid on the floor. Like, I can hang here. I can just hang out here and visit my grandmother at this point, right? It's just very comfortable, and it looks like a living room. So that's part of it. Oops, what did I do? So sorry. Can you fix it for me now that I said I could do it? There we go. There, they're cooking. It's real home, prepared, smiling. The bananas. And this is what I also really like, this little outdoor space that they can just come in and out of. That became really very, very important during COVID, but in general. They go out all the time. This isn't like once in a while. It's good weather, right? They go out a lot. Don't you like being outside? It's not a special thing. And it's not hard for the staff to get you out. You're running up and down the CNA, running up and down. I'm going to take this one out, now I got to take another one out, now I got to bring them back in. It's just so much easier to be able to do it. And it's all about relationships, and that gets back to staff. What I have seen, and there's research on this, Barbara Bowers from the University of Wisconsin has done extensive research on the relationship between the Shabazim and the members of the home, I'll say, as well as the nurse, the registered nurse, and the CNA. So let me just talk about that for a minute. So it's having these purposeful engagement, honoring natural rhythms. I'll let you all talk. I don't want to steal your thunder on that, but I did want to talk about the empowered staff a bit, because I have really looked at that, and that's why I want to keep saying you have to think about the staff. Who is running this, and why are they empowered? Well, it's a universal worker. Now, is that a term that you use? It sounds weird, doesn't it? Universal for everything. It sounds like you do everything. If you're any nurses in here other than me and Judy? Okay, so, there you go. So we used to do team nursing. This was like 60s, 70s, was team nursing. I think we're gonna go back to that, by the way, right? Because there's not enough staff. Team nursing means like the RN is here, and then there's LPNs, and there's nurses' aides. This is a hospital model, right? And so you have like functions. This one gives out the medications, and I'm talking a hospital model. This one does this one does the wound care. It's very fractured, but it's efficient in some ways. That's the purpose of this. Same thing with a nursing home in general, and hospitals too for that matter, where you have the food service, you have the laundry service, you have the direct care workers, you have the nurse that's supervising, all of that, right? In the universal worker model, the Shabazim is doing the direct care, the laundry, right? Yeah, the laundry, the cooking, all in once, right? And you think, and again, you should talk about this, like, really? You really want to do all that? Why do you want to do all of that? It's called primary care. In nursing, it was called primary care. Like, we even got the ice in the buckets rather than ask somebody else to go down the hallway giving out ice in the buckets, because you're doing all that, you have eyes on the person. You can see them. You can talk to them. You can relate to them instead of in and out, in and out, in and out, right? It's much more relationship oriented. And for the Shabazim, you can explain why they call them that, it is empowering. I'm in charge. I'm really needed. I am giving full care to this person, helping this person. I know the family. The family sees me. There's only, how many, 2 or 3 that you would have in this at any given time. Very consistent staffing. That's the relationship part, and that is part of what makes the staff feel good about what they do and honored by what they do, which we know is a big problem for direct care staff right now. We really have to work on that in general. So I wanted to share with you, listen, let me not screw this up again. I'll just leave it like that. 371 homes in 32 states is some data on turnover, because I thought you might be interested in that. Turnover in 2020 for CNAs was 33%, compared to 129% in regular nursing homes. 33% versus 129%. That's not good for finances. That means you have to recruit them, you have to train them, turnover is a big problem across healthcare. This is a big deal. You also then don't have that relationship. It's constantly moving. RNs, 63% versus 140%. So you still have nurses turning over, right? This is 2020 now, remember. I don't know what, maybe you have data more recent than this. LPNs, 41% versus 114%. So huge, huge difference. This affects dollars, quality, morale, and relationships. So I am more interested in the worker part of this than the small, private. I do want private rooms. Let me just go on record. I do want private rooms. But you've got to keep thinking about the staff. And maybe you can't have a whole universal staff. Maybe you can think about how much you can do that. Because a universal staff means you have to have the cooking and the laundry in the room or on the floor. So you'd have to do that. So that's pretty much what I wanted to share. We do need to talk about the barriers. Again, Robert's going to talk about that. I was talking briefly with Certificate of Need with Andy, who's an expert in Certificate of Need. New Jersey is one of over 30 states that has this, what I would call a barrier. It's like you have permission to have a nursing home and other people coming in can't have that permission. It's just very, very hard to have that, and we'll talk about that. So I just want to end it, I guess, with, are we setting up the care experiences we want for ourselves and for our family for the future? And the future doesn't have to be immediately, but it has to start. And it has to start in earnest. And it has to have champions. And you need government, and you need advocates, and you need providers, and we have to get together and talk more often, which we've agreed to do, right? So I'll turn it back to you.
Wonderful. Thank you, Susan. So we hope that we actually have conversation today and questions. We've built in time for each session. Luis is our timekeeper back there, so we'll just keep going till he tells us we can't. So we hope you have questions. As Susan said, I mean, we're just so thrilled. We do have government here. We have the Department of Health. We have the Department of Human Services. We have the Division of Aging. We have Medicaid. We have nurses. We have disability rights activists here, consumer activists. The Hospital Association is here. The industry is here. And we know that we need change, and we know that we can't get it unless we all work together. So I'll start us off with a question for you, Susan, based on the research that you have led at the Public Policy Institute. And I think maybe you've answered the question, but as you've done this research, you've produced these papers, what has really struck you the most about the small house nursing home, and perhaps why aren't we seeing more of them?
So I keep going back to the workforce. One thing I hadn't talked about it, again, Rebecca, excuse me if you're going to be doing more of this, but the training. They have much more training than CNAs, partly because they have to learn to cook, right? So they have other skills that are involved at, what is it, 160 hours or something?
Yeah, varies, but around there.
Yeah, that's a lot of training. So it's more training in how to care for people. How do you care for someone with dementia is part of it. It's not like an add-on. It's part of what they learn. And again, like doing the laundry, doing this. How do you work with families? All of that. And what I've heard in the research that Barbara Bowers and others have done, I haven't conducted it myself, is that those skills are really important to the workers. That's part of why they feel good, that they have these skills that they can, if they choose to leave someplace else, they have marketable skills, and it's helped their families. So they cook better for their families. This is what they say. They have healthier meals. They learn better nutrition because they have dietitians teaching them along the way. So again, the model of staffing and the training has been remarkable.
And based on what you've learned in terms of other states, what do you see as the next steps for us here in New Jersey? And I know Robert is going to get into some of this as well, but based on what you've seen, particularly in other states where they have more small house nursing homes, what is it that you think we need to do to help move this model along here?
What I've seen is the governor's office, frankly, and the legislature makes a bold move. And they've done it in various ways. I think it's Utah that the legislature came up with the idea of having, I forget how many, I'd have to look it up, I'll say 50. It was, do you remember this, Robert? I forget, 50, and by the way, it's a campus of, you don't have one home, right? You build several homes on a campus, basically, or within a neighborhood or whatever. So, and Robert will talk more about that. But generally, I think it was Utah did this, and they knew it was going to take like 4 or 5 years. So they had a planning together, but this came out of the legislature. New York's governor has put money in the budget. I think it's $150 million putting in about small homes and greenhouses. So having an initiative at that level is so helpful. Having the funding to get it going, having ways to address any regulatory barriers. You've got to have government involved in that. You can't do it alone. And then the other thing is having providers that are excited about the idea. Either because, as Andy was saying, you want to, what is the word you used, convert, or those that want to come in and show their way. In Arkansas, there's this provider who was successful in having Arkansas increase the Medicaid rate. It wasn't huge, but increase the Medicaid rate to the point where he was able to do 30-something himself, 30, and I don't just mean 30 homes, 30 different locations. So Arkansas, folks. Arkansas is a major leader here. Surely New Jersey can do something, right?
Yeah.
That's terrible. I like Arkansas, but really, they don't usually pop up as the leader of something like this.
No, that is true. So if Arkansas can do it, we can do it. So let me pause here and see if we have some questions from the audience before I hog everything. Commissioner.
You talked a little bit about scalability. You know, I'm looking at Andy and Teresa. I think we have about 75,000 individuals in our long-term care facilities. How many residents do we have now? It's decreased. It's something like that. So the scalability is really important.
Yes.
Because the homes that I've seen, and from my prior work experience, we had one of the first up in Massachusetts, in Western Massachusetts, Mary Meadows. The Sisters of Providence put it up, but the scalability was always an issue. 14 to 16 per home. And in a campus setting, you might then have to put up 10 homes. 150 million will probably let you put up 3.
Yeah.
So just have you thought about that?
Yeah, and again, Robert's going to talk more, but if you have to leave, Commissioner, maybe Robert should answer that immediately. I'm assuming you're not able to stay the whole time. Robert?
So I think scalability is the big question. I think the two things to keep in mind, and I'll talk a little bit more about this. One is we have to do something today to fix the broken tool that we have. Providers need it, residents need it, we want it for our families. That's going to take some money. If we put that money into the Arkansas model that Susan mentioned of a rate increase so that providers who are willing to build small houses have an additional add-on that pays for the capital costs. We know the operating costs are the same, but the capital, people aren't building new nursing homes, and Medicaid doesn't typically compensate providers enough to build a new nursing home. So a rate add-on, to me, is the way to scale. So then you allow the market to work through demand, and providers who are willing to take on the capital costs are compensated for that and are able to carry the debt that they need to have for that. To me, that's the easiest way, and it's the lowest burden on the state because it's not millions of dollars up front in grant dollars. However, as Susan said, grant dollars, grants for the training costs and additional pieces are very helpful to get things moving. So you can also take, many states take a pilot project approach. So they'll build 5 campuses of greenhouses to be sure that they feel that they work within their state system, and then you would want to scale with some rates. I think we have enough research that we don't really need to go through the pilot, but some states still feel that they want to do that. So it's really a rate add-on that I would think is the scalability factor.
Unfortunately, I think we only have time for one more question. Did I see Colleen back there, or Rini? Did you have a question?
I just wanted to add on to that question, which is how to get more facilities in New Jersey. The Green Hill model, if any of you have visited the West Orange facility, is amazing, but exactly the challenge of scalability and the cost per square foot of construction in New Jersey is so enormous that it's an obstacle for joining. So I think in addition to more proof, it's more incentives and more dollars from the state to really design these, as well as models that might be a little less costly that look at CCRCs that exist today and change some of those models to be more compelling, because we already have so many. Having been many, many years ago in the certificate of need process for facilities that wanted to first start up many, many years ago, we've watched them grow. And the question is, why don't we take some of the facilities that we have and be able to figure out how to design them with these types of small homes.
Sounds like a plan. I mean, I think there's different things that can happen. I do think that what you just said, Robert, I think it would be great if you had more greenhouses, frankly. I just do, because it's research, it's evidence-based, there's training materials ready, there's all of those things. That doesn't negate having other models as well, and you just described one. So I think choice is good. In fact, the commissioner started off that way, having choices, right? Maybe not everybody wants this. They might want something else. So I think we should have more flowers blooming, I guess. Is that the right thing?
We should. Well, that's a great note to end on. And Susan, Dr. Reinhard, thank you so much for being with us here
Thank
this
you.
morning.
Thank
And
you.
I'm hoping you can stick around. All right. Thank you.